All right. Good evening, everybody. Again, happy Thursday evening. Thanks so much for spending time with us as we dive into this important discussion around men's health. You might not know this, but June is Men's Health Month. And while Men's Health Month, our men's health issues happen all year round, we like to take the opportunity during June to place a more intentional focus on the education and treatment of men's health issues. So thanks for spending the next 45 minutes, an hour with us to join this educational webinar and prioritizing your health. A couple reminders as we get started. First, this presentation is completely anonymous. You are not on camera and no one can see your name. We do this because we really hope to have an interactive discussion. We want you to ask questions, even if you think they're embarrassing or you're not sure the right words to say. So to maintain your privacy, you can write your questions in our anonymous chat box at the lower portion of your screen, and we're going to save time at the end of the presentation to answer as many as we can. We've got quite a few people in attendance tonight, so remember, if you have a question, someone else probably has the same question, so don't be shy to ask. Our speaker tonight is Dr. Michael Kemper, who's a fellowship-trained urologist and men's health expert at Georgia Urology. Dr. Kemper focuses his practice around helping men who are dealing with men's health issues, like many of the men joining tonight's webinar. He's got a wealth of information to share with us this evening. So Dr. Kemper, thank you so much for spending your evening with us. I'll kick it over to you to get us started.
Hello, everyone. Thank you so much for joining me on a Thursday evening to talk about a subject near and dear to my heart, which is men's health. Specifically today, we're going to talk about erectile dysfunction treatment and management. My name is Dr. Michael Kemper. I am a urologist with Georgia Urology. I see patients in the Decatur office and the Conyers office primarily. I did my undergraduate at the University of Michigan, medical school at Albany Medical College, did a residency up in Augusta at the Medical College of Georgia, and then I did a sexual medicine fellowship down in Miami for a year. So today we're going to talk about erectile dysfunction. Erectile dysfunction. So what is it? It is the inability to maintain or achieve an erection that is adequate for intercourse. It is extremely common. About 1 in 5 American men 20 years or older will have at least one episode of erectile dysfunction at some point during their lifetime. More than half of men over 40 have some degree of ED, and it affects almost 40 million American men. How the erections work is a signal gets sent from the brain down the spinal cord to the penis. This causes the blood vessels in the penis to open up, letting more blood into the penis and filling up the spongy tissue of what's called the corpora cavernosum. That then fills out and blocks off the veins around the penis, around the outside of the penis, maintaining the erection. There can be issues at any point along that pathway. There are a lot of causes and comorbidities of erectile dysfunction. ED can be caused by vascular problems. That's the vast majority of ED, as well as nerve problems, or what we call neurogenic ED, or psychogenic ED, things like medications, testosterone issues, others such as that. ED and diabetes. So over 50 million men in the U.S. have diabetes. Patients with diabetes can also have issues with erectile dysfunction. It's a very common comorbidity. Patients with diabetes are more likely to have severe ED, so ED that doesn't respond to normal oral treatments. Some patients, it can be the first thing people notice. Symptoms of heart disease. So heart disease is a link to ED. Many patients have both. That's an independent risk factor in patients with ED for future heart-related events. And ED is correlated with the extent of coronary artery disease because those arteries that feed the penis are even smaller than the arteries that feed the heart. People typically will get mild ED symptoms before they get erectile heart disease symptoms. This is demonstrating that those arteries in the legs are the arteries to the penis are about 1/4 the size of the arteries that feed the legs, about 1/3 of the size of the ones that feed the brain, and about half the size of the ones that feed the heart. And so if you have vascular problems, you're going to notice that in your erections before you notice it in the rest of your body. Testosterone in ED. So low testosterone occurs when a man's body produces less testosterone than normal. It's more common with a lot of the comorbidities we already talked about. So obesity, diabetes, high blood pressure, high cholesterol. Super common worldwide, every 10-year increase in age, more likely to get more low testosterone. Testosterone can be treated, testosterone gels, patches, oral medications, injections. Typically, most people with low testosterone have more low energy, low libido symptoms, although they can have mild ED. Treating testosterone by itself may not help with erections, but it can aid somewhat. Prostate cancer and erectile dysfunction. So prostate cancer in and of itself does not cause erectile dysfunction. However, the nerves to the penis course right over the top of the prostate. And so any treatment of prostate cancer can impact those nerves, either permanently or temporarily. In addition, it can disrupt the blood vessels and make it so that there's more issues with blood flow to the penis. After a prostectomy, about somewhere between 25% and 75% of men will have some degree of erectile dysfunction. Even with a nerve-sparing robotic prostatectomy, ED can persist and can be permanent in some patients. Radiation, similarly, more than half of men will have some degree of sexual dysfunction after radiation. Peyronie's disease, another issue that affects the penis and can cause erectile dysfunction. It's a disease of scar tissue. So your body interprets an insult during sex or during normal behavior as a major injury and causes a dysplastic scar. So almost like a keloid, but in the penis. That scar tissue contracts, causing a curvature in the direction of the scar tissue. That leads to the curve, which can be painful for intercourse, as well as issues with penile shortening and erectile dysfunction. This can be treated with Xiaflex, so medicine that's injected into the penis to dissolve the scar tissue, as well as surgery to correct the curvature, stretching exercises, or in cases where people have severe ED as well, a penile implant is often the best option. We'll talk about more. Leading right into erectile dysfunction restoration. So there are, broadly speaking, 5 options for management of erectile dysfunction, really 4 that, in my opinion, work well. The pills, the injections, the vacuum device, and then the penile implant. I found that the urethral suppositories, most people don't like them all that much. Oral medication. So this one is the one that everybody knows already. I've seen the ads on TV, the Cialis, Viagra, the little blue pill. They work by opening up the blood vessels that go to the penis, making it easier to get an erection. They're effective in 60 to 80% of patients. Mild ED is very well treated by pills, and honestly, that is the first course for the vast majority of patients. However, a lot of people find that the disease progresses. This is particularly true in patients with diabetes or with very severe vascular disease. They also don't work well in conjunction with other medicines that can lower blood pressure, particularly nitrates for chest pain. They have some side effects. Headache, facial flushing, upset stomach is usually what people complain about. Intracavernous injections, or ICI, or Trimix is the one that most people have heard of. It's a medicine that's injected directly into the penis and develops an erection. It works very well in terms of there are multiple different strengths, and we can usually titrate it up to one that will get an achievable erection. However, a lot of guys don't particularly like giving themselves injections in the penis every time they want to have sex. And about 40% of men stop the therapy once starting it. And by a year, most people aren't still using it. It can cause some penile pain. The biggest concern is priapism, or prolonged erection. And it can also rarely cause Peyronie's disease, that scar tissue that I was talking about earlier. The vacuum erection device. So that's a device that goes around the penis and draws blood into the penis. Then an elastic ring is put at the base of the penis to maintain the erection. That works very well, or it works well, particularly for people who have a relatively lean body habitus and larger penises, just because most of it is involved in pulling that blood into the penis. It causes a sort of a cold penis and a little bit difficulty ejaculating. Most guys don't like it all that much. It can be a little cumbersome, but it does work. In my practice, we mostly use it for patients for post-radical prostatectomy, for penile rehab, so drawing blood in, or in patients who've had severe Peyronie's disease or a history of priapism that may have issues with scar tissue in the penis. as a way to have sex, it is not usually favored by most folks. This is called Muse. Honestly, I have not had much success with this. Most people have significant dysuria, and I haven't found most people get a really good erection. Titrating it up to get a good erection also generally gets to the point where people are too uncomfortable from the dysuria. I don't really prescribe this all that often to patients, although it is an option for some people. And then finally, the penile implant. So penile implant is a device that goes inside the body that gives you an erection whenever you want. So it's a pump that goes in the scrotum, 2 cylinders that go in the penis, and a balloon that goes up in the belly. And whenever you want to have sex, you pump the pump, it gives you an erection. The erection lasts as long as you want. Whenever you're done, you press a button on the pump, squeeze the penis, the erection goes away. That is something that is the highest patient satisfaction of anything I've got. 90% plus patient satisfaction, 90% plus partner satisfaction. It's something that works really reliably every time you want to have sex. Small risk of infection, about 1 in 200. Small risk of malfunction, mainly it's a mechanical device. It usually lasts between 10 and 15 years. Once it stops working, you take it out, put a new one in. Not any harder to put a new one in than it was to put the first one in. So 3-piece penile implant. It's the most implanted device. The Boston Scientific 700 is the one that has a built-in antibiotic treatment. We have been doing penile implants for over 50 years. This is something that is not obviously the same model. We've been updating it the whole time through. They are safer now than they have been at any point. The infection rates is lower than they have been at any point. And this is really well-established technology that we have been using for a long time. How does it work? No. 1 second. There we go. Okay. So the pump is inside the scrotum, the cylinders are inside the penis, and the balloon is up in the belly. Whenever you want to have sex, you pump the pump. It moves fluid from the balloon into the penis. That then stays there as long as you want. Whenever you're done, you press a button on the pump, squeeze the penis, the erection goes away. Essentially, it's a cure for ED. Usually performed as an outpatient procedure under anesthesia. I do the vast majority of mine at Emory Decatur. It takes me about 45 minutes. You go home later the same day. No catheter in my surgery unless people have trouble peeing, about 1 in 20 people. Usually done on the scrotum. Couple of days of pain, bruising, swelling. I tell people a 2 to 4 week recovery period. About half of people at that 2-week post-op visit are able to start inflating and deflating the device. People are having sex again between 4 and 6 weeks after surgery. Risks involved with surgery, that's true of any procedure, not any particularly higher with a penile implant. Not everyone's a candidate for it. The primary patients that I find aren't candidates are either not healthy enough for surgery at all, or for patients that have really poorly controlled diabetes. This is a device that goes inside the body. If there is, it does not make it so that you can use, if you decide you don't like it, you can't go back to using the pills or the injections. This is the way that it works. Although, like I said, 90% plus patients are satisfied with it. Can mechanically fail and need to be revised. Some men may have an increased risk of infection. It's about 1 to 2% for most people. Generally covered by insurance, most commercial insurances, and Medicare and Medicare Advantage. So this is something that we can typically get covered if people have failed other treatments, which we work our way through. 90% plus patient satisfaction, 90% plus partner satisfaction. Typically covered by insurance and Medicare. Permanent solution to ED. It's not something where you have to worry about whether or not your pill is going to work today, or if you took it too recently, or if you haven't waited enough time. Not have to go get your injections out of the fridge and do the injections, preserve some of the spontaneity. Typically, it doesn't interfere with ejaculation. You can have an orgasm before, you can have an orgasm after. Spontaneous, you can have it sex whenever you feel like it. And you're done, it lasts as long as you would like. Other treatments that you may have seen. AUA doesn't particularly approve of any of these. So Shockwave Wave, all of those, the evidence for it is really pretty bad. It has a small improvement on randomized controlled clinical trials. Usually most people find that is not enough to be clinically significant, and it's very expensive. Stem cell therapy and platelet-rich plasma, similarly, the Sexual Medicine Society of North America, which I'm a member of, and the AUA both say essentially that all of these shouldn't be considered outside of a randomized controlled clinical trial just because the evidence isn't good enough yet. Thank you so much for listening to me about ED. Now I have a period of time. So if you have any interest in seeing me, here's the phone number. And I see patients again in Decatur and Conyers primarily. And if you have interest in getting a visit, there can also scan this QR code, and that will take you directly to our online scheduling tool. If you say you're going to schedule a webinar slot, that will get you a direct visit into me that has been held open for folks who are watching these. At this point, I am happy to answer any questions that y'all have about really anything, particularly ED focused, but I am a resource for y'all. So if you have any questions, please fire them away.
Excellent. Thank you, Dr. Kemper. As a reminder, you can place your questions in the anonymous chat box for Dr. Kemper, and he'll answer as many as we can. So Dr. Kemper, the first one, is there a situation where someone would not be a candidate for surgery?
So primarily patients who are otherwise not candidates for any surgery, so poor lung function or heart function, we make people get clearances appropriately. The other is very poorly controlled diabetes. So patients with diabetes, my cut point for it is above about 10. I will not do the surgery. Increased levels of, it's a linear relationship between from an A1C of about 7 to an A1C of about 10.
Okay, very good. Could you talk about a little bit more about shockwave therapy and why that's not something that is recommended?
So shockwave, basically, the reason why it's not typically recommended is entirely because the evidence for it, and we have been doing shockwave in some form or another for years and years and years, and the evidence for it is not very good. It's just that there's exactly one randomized controlled clinical trial I'm aware of that showed about a 4-point improvement on the 25-point shim scale, which is not clinically significant for the vast majority of patients. It's just something that I don't feel like the bang is worth the extreme cost that is associated with it. The protocols aren't clear. Most of the places where you go, you don't even get the shock waves that was used in the clinical trials. It's just not something that I think is ready for prime time and may not ever be at this point.
Thank you. So this person says, will the pump increase the size? I don't know if he's talking about the vacuum erection pump or the penile prosthesis.
We can address both. So the vacuum erection pump, the vacuum erection device will increase the size somewhat over time. And I generally tell people, especially people with a lot of penile fibrosis, so people who've had a previous implant that needed to be removed for whatever reason, or people who have scar tissue from a priapism, that using the vacuum device will help to soften that up and gain a little bit of length back or help them maintain their length. The penile implant itself does not typically increase the size of the penis. So the goal here is for function. It's not for something that is going to look prettier or be larger. So I will put in the largest one that fits, but it's like, to a certain degree, putting a 18-inch inner tube in a 16-inch tire. It's not going to make the tire any bigger. It's just going to buckle the inner tube. And so people tend to have more discomfort.
That's such a great analogy. I've never heard you say that. Okay, can you use Viagra with Flomax?
You definitely can use Viagra with Flomax. They may drop blood pressure a little bit, so I would be cautious about it when using them together and be aware of that. But I have patients that use Viagra along with Flomax, definitely.
How long is your hospital stay after implant surgery?
I send people home the same day. I don't think we've admitted a patient for a penile implant in about over 2 years now. it's a relatively routine outpatient procedure. It takes 45 minutes. People go home.
Very good. What's your opinion of the system of mixing Viagra with Cialis?
So I have found that the absolute max dose of the pill, if we have someone that just Viagra or just Cialis doesn't work well enough, the absolute max dose of the pill that I will have someone on is I will have a 5 milligram of Cialis every single day, plus a Viagra 100 on demand when they need to have sex, about an hour before they want to have sex on an empty stomach. And what I have found is that that can rescue a certain percentage of men, probably somewhere in the neighborhood of 1 in 4 to half of guys who don't have an adequate result or have a barely adequate result with one of them independently will have a result that's adequate with both of them together. There is a slightly increased risk of sort of low blood pressure side effects, so that's something to be conscious of. But as long as they aren't on nitrates for chest pain, I found that it's pretty well tolerated for most people.
Would an implant still work with Peyronie's disease?
An implant actually is a lot of the times the best option for folks with Peyronie's disease. So if you have Peyronie's disease, or so that curve with scar tissue in the penis, and you have ED that's bad enough that pills don't work well, then I typically prefer a penile implant in those patients. It lets us do whatever we need to do to straighten the penis at the time of the surgery. And then also we don't have to worry about disrupting the function, because most of the conventional treatments for Peyronie's disease not only don't treat erectile dysfunction, they can actually make erectile dysfunction worse in a lot of cases.
I'm 74. Am I too old for implant surgery?
No. I think the oldest gentleman I've ever done a penile implant on is 83. That's a conversation between you and your partner. If you are still sexually active, people don't just stop wanting to have sex as they get older. If you're healthy enough for it and you would like to continue, then yeah, we should do it. It's not something where people suddenly don't get to enjoy life just because they're a little bit older.
What's your opinion on Trimix or Bimix?
So Trimix and Bimix work okay. They're injections. I prefer Trimix to Bimix most of the time. It's a little bit stronger, and I feel like you can use the different concentrations are down enough that you don't have the same levels of side effects with it in terms of the penile pain that sometimes people will get with Bimix. Like I said, we usually try it for most people unless they're totally unable to inject themselves. I have found that most guys will do it for a little while. Most guys don't want to keep doing it long term.
Okay, let's see. So this person says, can ED medications cause abdominal injuries or side effects? Maybe you could talk a little bit about the side effects that you see most often.
Yeah, so abdominal injury is not one I usually see, unless you give yourself a hernia, I suppose, if you're really working strenuously. But definitely ED medicine can cause, some people will get some blurred vision. Some people will have headaches. Headaches is the biggest one that I find people complain about. Some people get a little upset stomach. If you combine them with certain other medicines that drop blood pressure, you can get an unsafe drop in blood pressure.
Am I still able to orgasm after I get an implant?
You are. So this does not change that function at all. All we're doing is putting something inside that supports getting an erection. But if you were having an orgasm before, you'll have an orgasm after. If you were ejaculating before, you'll ejaculate after. So it is something that doesn't disrupt that. It just makes it a little bit easier it makes it functional.
What are some of the most effective vitamins or supplements that will treat ED naturally?
So I am not a huge supplement person. ED, there are not really proven supplements to treat ED. It's the same thing with you look online, all of these testosterone booster supplements. The evidence, again, is not that great for any of them. Now, living a healthy life, eating the things you're supposed to, all of that supports erectile health just as much as it supports the rest of your body health, because like we said, all of that stuff is tied together. But there's not specific supplements that I'm comfortable recommending just because the whole industry, it's tough to say, hey, this is definitely going to work. And also, it's something that's tough to say, hey, this is definitely what's in it is what they say on the tin. The regulation is just not there that I'm confident recommending specific things.
Very good. What's the difference between your office and the men's clinics that I always hear advertisements for on the radio?
So the ones that you hear advertisements on the radio typically do not have a urologist. They definitely don't have a fellowship trained sexual medicine expert. They don't offer the full gamut. They won't offer surgical treatment. They won't offer necessarily anything but injections, plus some of those other things that I already talked about don't work all that well. The other issue with them is they typically are cash-only businesses that are mostly invested in charging a lot more money as opposed to actually treating the whole patient.
If I have my prostate removed, am I still able to orgasm?
Typically, yes. So you will not see any ejaculate after having the prostate removed. But because that's the job of the prostate, is it makes about 50 to 75% of the volume of the ejaculate, and everything is plugged in via that. But you should still have the sensation of orgasm.
Does exercise help with ED and testosterone issues?
It does definitely help with testosterone issues. It can help with ED issues. In the same way that improving your lifestyle in general will help it. ED tends to be a progressive problem. So once you have it, it tends to get worse. It can get better if you improve your lifestyle and if you improve your overall physical fitness, but mainly that's sometimes not making it worse. So exercise is great for that.
So I had a radical prostatectomy, and is bladder leakage during sex something that's normal?
So it is not abnormal. It's not normal either. So it's something that every man's a little bit different. It's something that is something called climacturia. And so when you're having sex, part of having an orgasm, those pelvic floor muscles can relax. And so it can be tough to maintain that conscious sphincter control that you need to maintain your continence. And so a lot of guys will have that. That's actually something that we can treat. Either usually it's a adjunct procedure at the time of doing a penile implant. So for people that have ED that's severe enough and also are suffering from that, we can do a sling at the time of doing the penile implant that helps to support the urethra and keep that from happening as much.
Do you have any suggestions for increasing nitric oxide? Maybe you could talk a little bit about why that's beneficial, or if it is.
So nitric oxide, we talk about how PDE5 inhibitors, so medicines like Viagra actually work. What they do is they inhibit the breakdown of nitric oxide in the penis. And so that stays around longer and leads to vasodilation. That is something that it's not as though where you want that increased is just within the penis. You don't necessarily want nitric oxide increased all the way throughout the body. Laughing gas is nitric oxide. If you breathe in laughing gas for a little while, it doesn't give you an erection particularly. It doesn't really help your erections long term. It just, your body breaks it down immediately. That's part of what it does. So same thing with nitric oxide supplements that you can buy online. None of those really work to help ED because they're not really targeting what you need, which is actually directly in the tissues. And that's from supporting the normal pathways. So increasing your, making sure all of your lifestyle stuff is absolute as much as well as you can do it, or with the medicines that open things up, or the injections. The way the injections work is they turn those buttons on directly. That's how those work.
I thought that if the prostate is removed, you can no longer have an erection. Is this correct?
So yes and no. So the nerves, the penis course right over the top of the prostate. And so after the prostate is removed, almost all men have some degree of erectile dysfunction. Now, that doesn't mean you have permanent, total severe ED. A lot of guys will recover that function. That is usually over a period of about 1 to 2 years after the prostatectomy. And frequently it doesn't get all the way there. So what I usually tell people that are thinking about getting a prostatectomy is it means that if you have perfect erections before your prostatectomy, it may just mean that you need Viagra or Cialis and you can get an erection. It may mean that you need injections or penile implant. You may need more than that. And ED after a prostatectomy frequently is harder to treat with the conventional easy methods. I've seen some young guys have really good recovery. So men in their 50s who are otherwise super healthy may have full recovery over a year or two. Men who are older who already have erectile dysfunction are likely to have worse outcomes from an erectile standpoint and may need more treatment.
How many years will the implant work?
10 to 15 years for most people.
I'm not covered by insurance. How much is the cost for the penile prosthesis?
So that varies based on the provider. It depends on where you're doing it. We typically quote somewhere in the range of $20,000 as the out-of-pocket price for the cash pay price, depending on where it's done. Typically, it's in that area.
Which prostate cancer treatment is least likely to cause ED?
Active surveillance, so not treating it at all. Watching it as appropriate for people with low risk disease. That's part of why we don't treat patients with lower risk disease nearly as often. All of the treatments for prostate cancer cause some degree that actually work and cure the cancer at the right rate, cause some degree of erectile dysfunction. So what that means is that radiation and surgery both cause ED, and they cause it at about the same rates. The big difference between the two is that surgery causes much more of those side effects up front. So immediately after the surgery, people tend to get some issues with erectile dysfunction, whereas radiation tends to be more over time. So that radiation fibrosis, that scarring, continues to progress over time. People tend to get more of that leakage of blood flow out of the penis. That's what we call venous leak. And so while there's less upfront, within about 2 to 5 years after surgery, most people are after radiation, most people are in about the same place where they would have been after surgery.
All right, so I had seed implants to treat my prostate cancer with radiation, and I'm having trouble with pills and injections. Would the implant be my best option?
So yeah, for a lot of guys, that's the boat we're in. Is if it's, we try conservative stuff first in a lot of patients, unless the implant can be a second line. Honestly, I make everyone try the pills first, but if the pills aren't working and the injections aren't working, best option is a penile implant.
Okay. And then how long after surgery before you can have intercourse?
As soon as you can start inflating the device and the opening that we put the device in through is completely healed up. 4 to 6 weeks for the vast majority of patients.
Very good. Great questions tonight, guys. Okay, so I saved this one for last. I tried to schedule an appointment with you, but your first available is a couple months out. Can you get me in sooner? And I thought that's a great place for you to plug your phone number again and wrap us up, Dr. Kemper.
So the webinar address. So basically, if you scan that, it'll take you to our online self-scheduling system, Dash. And if you put in that you are a webinar, there are spots that are held open, 2 of them every day, that'll get you priority access to get in and see me. So that's how that it'll aid that speeding that up a little bit.
And also, if you call the office, just let them know that you came from a webinar as well, and they'll get you into one of those priority spots. Excellent. Dr. Kemper, thank you so much for your time. To all of our audience, we've not had a single person drop off during all of these questions, which is great. That means you guys had really good questions tonight and lots of good content. So thank you for joining us this evening. We certainly appreciate it. Dr. Kemper, any final remarks before we sign off?
Thank you guys so much for taking some time on a Thursday night to listen to this webinar. We really appreciate it. We do these for all of y'all, and thank you so much for coming with all the questions. I am here as a resource for y'all. Hope to see some of you guys in the office, and have a good rest of the month. Have a good 4th of July.
Thanks, everyone. Have a good evening.